From the Affordable Care Act to current guidelines and probably future guidelines, you're going to be seeing a lot and hearing a lot and reading a lot about team-based care models. And so, are there successful models with quality data and a positive bottom line? That's the question. And I am with Dr. Mary Norine Walsh, Medical Director, Heart Failure and Cardiac Transplantation, St. Vincent Heart Center of Indiana in Indianapolis. This is a major topic this day and age. What were you talking about in this packed session here at the CV Summit?
Yeah, it was very gratifying because it was packed and everybody's really interested in it. I think what's happening, we used congestive heart failure as kind of the model to talk about, because it involves care of patients with congestive heart failure, involves a lot of disease management and that sort of thing. And it is the ideal way to get the team involved, and it is also the one where teamwork pays off in the bottom line. And one of the reasons is, for example, readmissions. Readmissions
critical
are huge,
issue today.
Right? So it really takes a whole village, a whole team to do that. From the inpatient side of things, to identify patients with heart failure, for case managers to help get the patients to have a visit within the first week after discharge, and then in the outpatient side, who cares for those patients? Often it's nurse practitioners, PAs, nurses, along with the physicians. So congestive heart failure is a great model. And I think what's happened, the reason team-based care has become such a big topic now has partly to do with hospital integration. Physician groups cardiologist groups have integrated. And so the quality incentives are now aligned, and people are really interested in the quality measures. They're aligned with the hospital. And so readmissions has kind of become everybody's problem, not just the hospital administrator. And utilizing all members of the team makes both quality sense and business sense.
Now, for the longest time, doctors have been the stars of their own profession. And now, if this were a sports analogy, they've been used to the single sports, and now it's a team-based sport.
Right.
What's the issue? What's the cultural clash that you run into?
For years, not so much now. I think integration has changed this. What I call the lone wolf cardiologist wants to do everything. Just see his or her own patients. I don't need anybody. I may need a nurse now and then, but I don't need a nurse practitioner or PA to do that. And I think that's slowly changed with the understanding of what the patient needs, but also what the incentive is. And so I think the doctors are more open to the team. The other thing that's changed is I think there's understanding that the cardiologist isn't always the leader of the team, shockingly. So that's something that's new too, is if we have somebody who's having issues with their medications, it may be the PharmD or the clinical pharmacologist who is the person who's taking the lead on helping that patient. And I think over time, the doctors have gotten a little more used to that. We still have some growth areas and there's some laggers, but I think we've made a lot of progress.
Using heart failure as an example, how can it succeed? How can team-based care make a difference?
Well, I think as we pivot from fee-for-service to value-based purchasing, that's when the team, I think when people stop worrying about their own RVUs and their fee-for-service, their E&M codes, and think of the patient care and looking at covered lives, then team-based care is going to just flourish then, because I think there's still a little bit of tension. I mean, we're still in a fee-for-service environment, and so people are to some extent still interested in preserving income. So I think as changes come, care will be embraced, and I think we'll have many more members of the team, and in fact, fewer physicians. There are some practices, I was saying in our session, there are several cardiovascular practices in the United States, not ours yet, where the numbers of PAs or nurse practitioners are equal to the numbers of cardiologists. Now, I think that's a healthy practice model.
Once you get a successful team going, is it easy to expand? I mean, the guidelines I was talking about, TAVR, it should be team-based care.
Right.
Determining PCI versus CABG, team-based.
Right.
Once you get whether it's heart failure or whatever, is it easier to get the next team going? Is it easier to work with that?
Yeah, absolutely. I think heart failure has led, and I think slowly the other disciplines and the other disease states are coming along. I mean, a great area that I think is probably underused still is those patients who are stable with arrhythmias who need device follow-up. And that's been the bailiwick of the EP doctor, but the EP nurse practitioner can certainly be involved. So I think as there's more success with heart failure. We see, in fact, I told a story from a long time ago that the early success of our heart failure clinic, myself and a nurse half day a week, 17 years ago, I knew we had success 3 months in when one of my colleagues sent a patient with lung disease to the nurse. That meant that the model had transferred.
So you think it is time for an EP doctor to start thinking about team-based care?
We're planting the seeds. Yeah, yeah.
Any other areas where we need to plant seeds?
You know, I think TAVR's been really dominated by the surgeon and the interventional cardiologist, and I think I think they're doing a good job in realizing that especially the post-operative care can be really done well with non-physician members.
Well, we have so many different issues that have been part of the CV Summit here 2015 in Orlando, so please make sure you see our cover story in CardioSource World News and the variety of different interviews that were done right here at the CV Summit for CardioSource World News. I'm Executive Editor Rick McGuire.